Hey, this is Anthony Davis.
This is Blake Loxterkamp.
And we've got Dr. Alex Sundin with us, who is a chiropractor and teacher and part of the Human Performance Center at Northwestern Health Sciences University. Dr. Alex, welcome.
Yeah,
thanks for joining us.
Yeah, thanks for having me, guys.
Yeah. So I figured we'd start off with just a couple of general, get oriented on the map sort of questions.
Cool.
So chiropractic, what brought you to chiropractic? So straight up.
Yeah. Well, I guess long story since we have time. I was an athlete growing up in high school. And when I got to my senior year of high school, no, that's not true. My sophomore year of high school, I started to use chiropractors. My mom had low back pain, and she's had back pain for a long time. And they used to say that she has degenerative disc disease. Yeah. And she had a increased lordotic curve, and that was the cause of her pain. and so she would go to a chiropractor, and of course it would feel great, right? And she'd get relief, go about her day, things would get better. But she'd have these episodes currently, and when I was young, I was just I'll go, why not? And the chiro came through my town when I was a sophomore, and he was graduated from Northwestern, and he was a wrestler at the University of Minnesota. And he was like, all the elite athletes do this, you should do it. Great marketing, right?
Yeah. All the cool kids are doing it. So.
A 16-year-old kid, and they're like, you want to be a pro? This. And so he's a great guy. I have a great relationship with him, but I just look back on it and I'm like, that's a funny way to do that. So anyways, I went to him. I get seen every once in a while. He gave athletes a really great deal. So in the long run, it probably wasn't super lucrative for him, but good to get inspired. But that's really what got me into chiro. So I went to undergrad. I went to Augsburg. And when I was at Augsburg, all my professors were like, don't do chiro. That's no, don't do that. You can do way better than that. And I was like, well, that's kind of weird.
Yeah.
I like my chiro.
What was your undergrad?
I was pre-med.
Okay.
Yeah, so I got as a freshman, you're doing generals and all that stuff that they make you pay for, right? Mm-hmm. And I was like, okay, well, maybe I'll do med school then. I'll be pre-med. And so I went the pre-med route, did all that stuff, and that was fun. I learned a ton, right? I had a lot of good experiences. And I graduated, and I took a year off to scribe in emergency rooms throughout the metro. So I worked in downtown Minneapolis at Abbott Northwestern. I worked at downtown St. Paul at United. I worked in 3 freestanding ERs, one in Cambridge, one in Plymouth, and then one in Hastings. And I would go there, and that was my job after school, I was a scribe, where I'd go in and take notes for ER physicians. And I just follow them around. I didn't take any medical terminology classes or anything. So
trial by fire.
Yeah, so literally the first 3 months, every day I'd get home, I'd be like, I can't do this. I'm quitting. Tomorrow, I'm quitting. Going in, I'm being done. You get paid $9.50 an hour.
Yeah.
Terrible. You work overnights, you work weekends, you work everything. So you work ER schedule.
Yeah.
And you get paid nothing. But you're gaining all this experience, right? So on one hand, I'm like, I really loved that experience. But then when I was in it, this sucks. But 3 months went by, got my footing, picked it up quick, and then I was a pro, and it was easy, it came natural, and that's how it always goes for everyone. It's kind of right into the fire to start, and people that sink, they are done. They wouldn't have made it through med school anyways. It's kind of their way of ruling people up.
Yeah, totally.
But through that year, I did that. So I worked in emergency rooms. I then worked I shadowed a hospitalist who was acute stroke. And then I also worked with a orthopedic surgeon. And I came to the conclusion probably around 6 to 9 months in that I was I don't want to do this. Everyone was a statistic or a number, or no one was a name. And then the ER, I kind of get it, but there needs to be some sort of empathy and personality that you do when you're taking care of people, especially when they're in the ER at their worst.
Yeah.
So it was just it was my first hand of this is a really broken system.
Yeah.
ER physicians at that time was their lifespan was 4 to 6 years. They also had the highest suicide rate of all physicians. So it was just crazy stats that would get chucked around. I was in the ER, and we worked with a doc that was from Boston, and he worked at the big Boston hospital that took care of people after the Boston bombings, the marathon bombings. So I was in the ER when that happened in Boston.
That must have been crazy.
And he was calling people in the Boston hospital, his friends, and being like, are you okay? What's going on? You know? And the days after it, when he finally heard it, he said that it was like a normal day. And then busloads of people just came in, like one after another, continuously. When hospitals get so full that they can't, especially like in the different like levels where you're sent up to different floors, when they don't have any more beds available for patients, they will go what's called on divert. And what it means is ambulances just stop coming to the hospital because they know there's no more room. They were on divert for like 24 hours, which is not good. Yeah, it was crazy. And so all of this, every time I'd see a patient, it would be that we got to do these things. Someone with, I remember low back pain. People would come in, they wouldn't even see them x-ray.
Weird.
Ultram and the early stages when I first got in, it was just when we were capping opioids. But when I first started, it was like Dilaudid, which is a high-powered IV opioid drug. Before they even saw him.
Wow.
No exam, no history, nothing. I'm the scribe, so I always go in right when we see him. We wouldn't even go anywhere. I would just start putting in procedures into the notes before we even took a history, which is like, yeah. And everyone did it. It wasn't like it was just one doc. That was how they did it. Until I would go up to like Cambridge or Hastings, where they would typically be a little bit older, savvier docs that kind of would buck against the system a little bit, and they would do the right things. And they would be like, you don't get pain medication. There's nothing wrong with you.
Sure.
Yeah.
You stand up, touch your toes, sit down, and they do. So they'd stand up, can't touch your toes. Oh, like so bad. Like, oh, you know, sit in bed for me. All right. Can you bring your knees to your chest now? And they'd like bring their knees up to their chest, right? Lumbar flexion, like full terminal lumbar flexion. And they could do it with ease because the patient was looking for opioids.
Yeah.
But the guy would not order image. He wouldn't give anything. He'd give him Tylenol and say, you're going to be discharged.
Yeah.
And I was like, that's not how they do it in the Metro. And he's
that's different.
Yeah. I was like, what? Like, cool. You know? So I then started realizing that, okay, that's not how things work in the medical world. So applied to chiro school. I was planning on going to Chicago to get National University. And then I met my wife. So then I came to Northwestern. Went to Northwestern and really enjoyed my time, but about T5, so right where you guys are at right now.
Exactly where we are, yeah.
I pretty much had like a mental meltdown because you've already spent a good amount of money, half the amount of my cost, right? And I was like, these people are crazy. Like this like...
What do you mean? Chiros are crazy?
Subluxation, a line, like that is not right, you know?
Yeah.
And I didn't even know why it wasn't right, but just like logically in my head, I was like, that can't be right.
Yeah.
You know, like that just not how it works.
So you had no idea about any of that going into school?
Yeah, no.
You just thought we were like, sort of like PTs.
Yeah.
Yeah.
And I didn't even know what, I didn't even know what a PT was. I never hurt myself.
I was the exact same pre-med student as
Yeah.
you.
Yeah. I had like no clue. PT was never offered to me, which is really interesting.
Huh.
They did. They said, don't do chiro.
That's so weird that they wouldn't then
Never
give you the
mention-
alternative, like,
Yeah.
because that's usually the alternative. Don't do chiro, do
Never
PT.
mentioned PT.
Yeah.
And would say either PA or MD or DO. DO is another one I got pushed towards a lot.
Yeah.
So I was like, okay, well, let's do chiro. So T5, fast forward, and I'm like, I don't like this. Like, I'm going to go back to med school. You know, this is crazy. People are saying things that, like, they cure cancer. I got people doing like spinal network analysis, flailing around on the table like they're having, you know, a good old time. And I'm just like, this is nuts. This is nuts. So I was really close to pulling out, and I met Dr. Stark.
Yeah.
Yeah, and I met Dr. Stark, and Dr. Stark was like, do you like sports? And I was like, I was an athlete.
Come with me.
Yeah, that's kind of, I don't think that's how it went, but in my mind, you know, like we kind of, we remember what we want.
In from on high.
Yeah, exactly.
Yeah.
He just like gently kind of was like, come look at this, you know? And And that was the end of it. I would go to grand rounds, which we have in the mornings on Thursdays now, right?
Mm-hmm.
Are in one of the biggest classrooms. Well, they used to be downstairs in a tiny little conference room with about 3 people.
Mm-hmm.
And Dr. Stark was one of the 3.
Yeah.
Right? And that's how it started. And we'd go down and we'd look at a journal article and we would just go through it. And if we had a case, he'd make us make a PowerPoint presentation and bring the case in, and we'd go through a case together.
Cool.
Just like how we do now. We didn't have all the acronyms in play, Hippie-Ronells and Last DC and all that stuff. We didn't have that stuff, but we would just go through his flow.
Yeah.
So that changed my mindset. I got involved with ACA Sports Council, got to do more sports events, got my EMT license or certification. Then I did sideline stuff for a while to make a little money. And then as I was a T9, we had the Seahawks played the Vikings in the NFC Championship or something like that.
Sports ball.
Sports, yeah, exactly. Clearly I know a lot. Here's the thing about me. I don't know anything about really any sports, but I know a lot about hockey. Like that's my little niche, and that's pretty much where I'm at, you know?
Even as a hockey player, I don't know shit about hockey.
yeah, that's like my realm. I don't know much about else. So, anyways, long story short, the chiro for the Seahawks came. His name was Jim Kurtz. I got to meet him. We really liked each other. Didn't think much about it. As a 9, I was like, I should go somewhere else for my T10 and be a good experience. Walked into Dr. Stark's office, was like, hey, do you know anybody in Seattle or anything like that? Like, that sounds like a fun place to go. He's like, well, you just met Jim. Did you talk to him at all about it? And I was like, does he take interns? Like, I didn't even know he did that. And Stark just kind of laughed at me and shushed me out of his office because he's on a phone call or something. I was like, oh, I don't know if that's good or bad. But 2 days later, I'm sitting in class and I get an email and it's like a forwarded exchange from Kurtz and Tim. And it's Dr. Kurtz saying like, so excited to have him. Can't wait till he gets here. I was like, what?
Okay.
Yeah. So,
Guess that's settled.
That's that, yeah. And so I went out to Washington and that's where I started my practice. And that's where I kind of developed into like the rehab style and more flowing towards hard literature and trying to make everything evidence as possible. And that's kind of where I'm at right now.
Yeah. So you didn't know all the drama that's in chiro until you were in the heat of it.
Yep.
That, it seems like a lot of our classmates are just shocked by that when they realize kind of the debates that are going on and that there are any people that just straight up reject scientific evidence on things. I mean, I understand that learning is a process and we have to, it's, you know, you can't just immediately have a global, I mean, the ship is too big to steer it immediately, but there's so much resistance. I mean, I knew about that ahead of time and I still was like, I'm going to go for chiro.
I like it.
But that was a weird decision, I think.
Yeah.
But I'm curious what, like, just generally speaking, what is a chiropractor?
I think a chiropractor is a type of healthcare practitioner that focuses and specializes in MSK injuries. That's what we treat. That's what we're good at. Yeah. That's all it is.
And MSK being?
Musculoskeletal.
Yeah.
And neuromusculoskeletal for sake of PC.
Sure.
Yeah, I think that's it. That's what you are. You're not a Subi Slayer. You know, that's the kind of joke. You're not a chiropractor that does chiropractic. Like that's not a thing, right? That's made up. That's crazy trained people trying to silo themselves because they're worried that evidence will show that what they do isn't necessarily the best thing for their patients.
So pretty much similar to what a PT does. Right.
I think that there's a few distinctions. So I always blur that line. Like what does a PT do? What does a chiro do? And are they one and the same? And I think that they're super close. I think we come at it from different angles. One, PTs come at it from movement based right away. Chiros come at it from more biomechanical based right away. And now biomechanical and movements could be, you know, whatever. They could be one and the same. But I feel like as a chiro and most chiros, they tend to look at only like joint function right away. That's their first thought. Adjust, right? And I think that you could say the same with your classmates, right?
Yeah, everything is adjust that.
Yeah, right. You're going to go right into it and find out what you need to manipulate. Whether you're really bad at it or really good at it, that's where you tend to start.
Yeah.
PTs tend to start more along the lines of, well, let's go through, they go back to protocols, not all. They go back to protocols and say, you have shoulder pain. All right, we're going to start through the shoulder pain workout flow. We might do some soft tissue because they do. They might also manipulate, right? It's a little bit different than how chiros do it, but the real big distinction is that we're trained as primary care physicians. They're starting that changed when they changed their doctorate of physical therapy, right? Their DPT.
Yeah, because they can diagnose too. They have to do
correct
a differential. I mean,
yep. They absolutely
to put that D.
Yep, and but I think our training is similar to an MD rather than similar to a PT in regards to how we are trained in school. Okay. Now, in my personal view, we are heading down the path of being one type of practitioner. Whether you're a PT, whether you're a chiro, whether you're a some other manual therapist, like a physio, which is just PTs in other parts of the world. Yeah. I think those lines are coming together and closer, and I think they'll continue. And what will be is just an MSK practitioner. Right. Yeah. Period.
Somebody was talking about that in the FTCA page the other day, that they mentioned kind of a merger between all of the musculoskeletal practitioners, whether that's chiros, PTs, acus, massage, all of it, essentially doing kind of like a feeder program in the way that medical does, and then you specialize and you go and do a residency in whatever you want to get good at. Yep. But if we had like a year of basic sciences, or maybe a year and a half, or whatever it is, to get your basic sciences, movement, exercise science, that kind of stuff. And then those who need more, like chiros would need more training than if you wanted to do massage. Then, a massage residency to become an LMT would be maybe a 6-month thing. And for us, we got a few more years.
That would be cool. But a lot of people don't make money that way.
What do you mean?
Like, the reason why I think we're so siloed and why we strict to professional lanes is because if chiro school and DPT school are one and the same, we don't need them both.
So what?
Yeah, but that means one of those schools loses all its funding. All the people that work at that school lose all their jobs.
Why wouldn't they just convert it? I mean, why couldn't they just be, if it was, what do they call it?
Because then the chiropractic or
physical medicine doctor or something
PMNR, like that. Chiropractic association would go away then. PT association would go away then. Because we're all one thing.
Okay. Well, who cares about the associations though? The schools could still function as primary physical medicine school.
You're looking too close. Go 30,000 foot. Okay. Right? When things are become efficient and they merge things together. Right. Let's think business.
You trim the fat.
Yeah. Lots of people lose their jobs. Yeah. And lots of people lose, and money is really what it comes down to. If mergers happen like that, somebody's going to lose jobs and money, and that's not good business. So why would you ever want to do that? Now, that's not saying, is it the right thing to do? Maybe. But will it ever happen? I would skeptically say probably not.
But I mean, that's basically what happened with osteopathy in the United States, right? I mean, they maintain their distinct schools and titles and all their organizations and everything, but they, a DO student can go and do the same exact residency that an MD student is, and they get the same exact scope of practice. In the United States only. I know in other parts of the world it's totally different, but in here they're treated the same. You could be a neurosurgeon and be a DO, so it doesn't.
Yeah, I don't know. I don't know anything about DO programs. That's where I applied for schools, but that's like my extent of knowing the DO scope and things like that. I would say that out of the MDs I know, they still kind of poo-poo on their DO friends.
Yeah. I was thinking about DO and MD as well before going to school, and it seemed like there was still some of that bias, but that they were kind of getting over it. Yeah. I think that part of it is that in other parts of the world, DOs are more in off in this anti-science realm that we chiropractors get a lot of shit for this, because some chiropractors there still in the United States, but I think they're still kind of carrying that baggage with them.
Long and the short of it, would it be an awesome idea and would we probably get better results? I think so. Do I ever think it'll happen? Probably not.
Yeah. So if we merged, I know I can hear that a lot of people are getting really pissed off about the idea of like losing what makes us unique, and that chiropractic is not. I mean, the people who are like clinging to the original vision of chiropractic. That chiropractic is this. It's not about your muscles and your bones. It's about restoring your body's ability to heal itself. It's kind of this big, which I love that picture. I love the idea of helping a person heal themselves. I think in general we can still maintain some of that, but I'm curious. I mean, do we lose something? If so, what are we losing? Maybe we are losing some things. Some of that OG chiro stuff. Is that a bad thing? What are we losing?
I don't know.
Does it matter?
Yeah, that's a good question. I don't know. I don't have an answer to that. I think being like, would I feel any less? Let's just say this. Would you feel less if you graduated from a DC program, you spent 3.5 years, and this is just a completely random thing, and maybe this won't even make sense when I say it out loud, but like, no, we're not going to call you a strength coach. Would you feel offended by that?
If I had the same scope of practice.
Yeah, everything's the same. We're just gonna call you a strength coach.
No.
Yeah, I feel like you might be asking the wrong guy, because I knew about all the baggage that came with the name chiropractic before going into school.
Yeah.
And it was it was the scope of practice that I was like, I looked at the scope for PT, I looked at the scope for medical doctors and the training, and chiropractic had a scope that was sort of in between those two realms.
Yeah.
Like I don't like the baggage that comes with it, but I really like what I can do with that license.
Yeah.
That's what I want.
Yeah. I don't know. So your question is, would it be bad or good for us to lose our title, essentially, right? Is that what you asked?
Well, because if we lost
our uniqueness,
if we merged, then we wouldn't be teaching philosophy classes.
Yeah, well,
nobody would be mentioning the word subluxation.
That's also a good thing.
You.
Yeah.
Yeah.
Well, so just to weigh in, and maybe this is just a quick point or otherwise, but there's a lot. I've read a lot of. I'm in forums and all over the internet, and people get the internet's a bad place to hang out. Just, disclaimer. But I hang out there.
It's like, that one, like, bad street, like, he hangs out on that. Don't hang out with him.
Don't hang out with him. I hang out with the trolls under the bridge. That's my kind.
Exactly.
But it's like a lot of people get the first thing that people who are anti-chiropractic, the first thing that always comes up, and this is the thing that drags our name in the mud, is that as soon as you say, hey, chiropractors are people who fix subluxations. Oof. And that's what and so they're saying chiropractors suck because they care about subluxations, which are a made up thing.
Yeah.
Right?
Yeah.
So I guess just to weigh in on that, what is a subluxation?
Yeah.
if you don't mind.
Yeah. No. Oh yeah. It's easy. A subluxation is a partial dislocation of a joint. And here's how we got here. I don't actually know this. Do you guys know what the green books are?
Yes.
Okay. That's unfortunate. Yeah.
Yeah.
It was real. I had like a really tender moment one day when I looked at my active care group, and I was like, "Do you guys know what the green books are?" And they were like, "What?" And I was like, "Yes!
We're winning!
Things are
progress!"
Yeah, exactly. But so I've never read them. I don't know what they are. I mean, I know what's in them, but I think that when B.J. Palmer first, which is the guy that invented and gave legitimacy to chiropractic, when he first, manipulated the guy that had the ear problem that all of a sudden then could hear.
Oh, when Dee Dee did that?
Yeah, Dee Dee, sorry. Yeah.
Whatever.
It was clearly I know. Okay, whatever. The old guy with the beard.
They were both a little wacky,
so
it's easy to get them mixed up.
So when he first adjusted something, right? And I hate the word adjust too. Like I don't know. Anyways, when he first did that, he felt something.
Mm-hmm.
He heard a noise.
Yep.
That kind of snap, crackle, pop, and then the symptom was resolved. Well, in 1800s, you didn't have like Google. You had a book that you'd look into that maybe was accurate, maybe wasn't, because there's all sorts of different information all over the place. That who knows if it was accurate, but probably looked up what does subluxation mean, It means a partial dislocation. And he goes, well, that's probably what I felt.
Mm-hmm.
It was right rotated. I put a thrust into that area, put it back into alignment, which is where all these words come from, right? Mm-hmm. And I cleared a subluxation of the vertebra.
Yeah.
I see how you could come up with that idea.
In 1800, but now when it's 2020, that doesn't make sense. We know that's not what's going on.
Go on to PubMed and figure this out.
Right. Yeah, but it's like a lot of words. And I don't know how you gotta search for and you gotta know the keywords.
Or you can have an app on your phone.
It's really hard.
But that's where I think. And what's wrong with that? Logically, at the time, that made sense.
Yeah.
Okay.
Those words, that language, that thought, that made sense. Today, even 20 years ago, even 50 years ago, honestly, we should have known that that's maybe not what we're doing.
Mm-hmm.
Right? We're doing something, but probably not that.
Mm-hmm.
And if we could have done that, we probably would be in a different place than what we are today.
Mm-hmm.
Yeah.
And what the evidence right now shows is that, we may not even actually move bone or anything like that. We may neurologically affect the soft tissues around it,
Sure.
which then maybe increase space within the joint, but that's it. And it's temporary, and we don't really even know if it decreases pain consistently.
Sure.
Now, anecdotally, all of that stuff, I think, happens. I think there's sometimes where you do probably affect the actual joint. I think an HVLA thrust always addresses some sort of neuro component, right? We know that even when you flick skin, when you're doing a surface MMG, you see stuff running up to the brain, right? But, and that goes with everything, we could talk about pain, and that would take us another 4-hour show to talk about, but I think we still don't know. Okay. I think that what evidence shows us right now, long and short again, is manipulation is effective for a short time, and when paired with movement or exercise, has longer lasting, better, more efficient results. That's what we know. Greg Lehman is a PT and he was a DC, and he talks about, why do we care there's a certain time and a place for understanding what it does. Why does this work? But why are we not asking who's going to benefit from this more?
Sure.
Mm-hmm.
It's about
how would you know if you don't know what it does, though?
Finding the right type of person that's going to be affected appropriately by the technique or the treatment.
Right.
Maybe the focus of what it does is less important than who it's going to help, right? And that's a mind shift in regards to science, because we want to know what it does, because then we know if we can find the thing that's not right, we can implement that. But in musculoskeletal, there's so much psychosocial factors that you got to pay attention to, that even the things we know, like a disc, really common signs and symptoms, we actually don't know if that's actually the pain generator.
Yeah,
right? Those studies looking at lumbar disc herniations in asymptomatic to symptomatic individuals. And there's the same author posted 2 different papers. One that started with, there's a ton of people that have disc herniations that are asymptomatic, so maybe a disc's not a problem. But then he followed it up with a paper that's but there also were a ton of people that had disc herniations that had symptoms.
Yeah.
Right? And so it's this line, right? We know some stuff, and our physical exam will take us to a certain point, but then we also need to understand that we don't know shit yet. And we have a long ways to go, and we need to start asking better questions to get us to a better point.
So if you're talking about, you kind of jumped over obviously some issues that could be really blown up, but in general, if you're suggesting, and I've read a lot of that same research too, that your structural damage doesn't necessarily mean that thing that's damaged is causing your pain. You can have pain without having any damage, any weird combination
of damage without any pain.
Yeah. So because of that, I was wondering something, and then my brain, it did this thing where in the middle of midterms after freaking 8 exams,
shorted out on you.
It's just like, it was like,
that's okay. That's okay.
Oh, yeah. So if those things are unreliable as outcome measures, if we don't know if the structure is the problem, it's been suggested, well, just go be a therapist then. Like, what do you say to that?
Yeah, and I get that, right? That is the extreme side of the conversation we're having, right? Mm-hmm. I don't know if it's America or if it's just people in general, but we love like extremes, Like if I'm a Democrat, I'm a progressive liberal, and you suck if you think anything red is cool, right? And then vice versa. If you're on the far right, you're Tea Party, and like all of that, right? So it's like there's no moderation, and I think that's the same. Well, especially on the internet, everyone loves to be polarizing because when you're polarizing, guess what?
You get likes.
We're entertaining. We're entertained by that.
Yeah.
Yeah. So it's good to be polarizing because, well, I get a following then. And when I get a following, I get money. I can sell my course.
Yeah.
I can sell a book. I can do seminars because there's tons of people that want to hear me talk now, right? Mm-hmm. And it's not always that way, but you know what I mean. Mm-hmm. So you have to understand that it's more complex than maybe what we understand. And that's all you need to know. You don't need to discredit what we have literature for. Mm-hmm. And you also don't need to discredit what we don't have literature for. Now that's a slippery slope, and I get that. Yeah. But there needs to be some level ground. Why can't I say, it's probably a posterior disc herniation. Mm-hmm. We're going to treat it like that. It may not be. We're still going to treat it like that.
Right.
And I'm going to work with you through these things. The long and the short of it is, no matter what you think it is or what you do to treat it, if the goal is be economically efficient, don't make the patient spend $8,000 to see you for a year. If you can be efficient, get the patient through pain while encouraging movement and empowering them to take control of their pain, you've done your job.
How do you see patients respond when you're like, well, it might be this? Because a lot of times doctors are like, it's this, here's the thing.
Yeah.
Do it.
I don't notice any different. When I was like a first year associate and I was real confident because I was like, fake it till you make it, right? Just, this is a disc and this is why.
Yeah.
And people would be like, okay, let's do that. And then guess what? It wasn't a disc, and it took me longer than what I thought. And they would be like, this guy doesn't know what he's talking about. Leave.
Because you changed your mind later.
Yeah.
Yeah. Sure. You were so confident.
To now, where I'm like, no, might be this. Kind of looks like it's that. Mm-hmm. Let's treat and find out, and we'll see how it goes. We'll take it one visit at a time. People are usually like, okay.
Yeah.
Sure. And then I have some room, because if it is what I thought it was, score. Mm-hmm. And that happens. Mm-hmm. And then the other side, another 50% of the time, it's not what I thought it was, and I have to reroute and change and do different things. But I've never closed the door off on, I know exactly what this is, and this is how it responds. Mm-hmm. I think when you start doing definitives, one way or the other, is when you got a problem. This 100% works. This 100% doesn't work. Well,
yeah.
I think people are weird. Some people like when you wave crystals over their face and tell them that they're healthy, And guess what? What we think tends to be what comes to fruition.
Yeah.
There's so much about the brain we don't know. It controls a lot. It also is sometimes really dumb when people think it's real smart because it's primitive, right? And sometimes. So it's this weird balance you have to have. You can never be black and white once you have a doctor attached to your name in any shape or form. PT, MD, DO, whatever.
Sure.
You always have to have, maybe, we think this is the best direction. This is what we know seems to be the best treatment for that. Let's see where it goes. Most of the time it works.
Yeah. I was watching a debate with Deepak Chopra.
Sweet.
And Richard Dawkins. I think it was the two of them. And they were, who cares what they were debating about, but Deepak said some stuff about quantum blah blah and whatever. And then Richard was like, there's this thing that scientists do when they when they're trying to come up with a statement about anything, they're always trying to hedge their bets and leave room for uncertainty. And just because they recognize that there's a high likelihood that eventually somebody's going to come out and tell them that they're wrong.
Right, yeah.
And you don't seem to have that, that mental, like...
and that's...
I've noticed that a lot is what I'm saying.
Yeah, well, and that, you bring up a great point, right? And you mentioned this earlier off camera. I was like, well, how do you react when... Is it okay to be wrong?
Yeah.
Yeah, like when you do something for 20 years and then all of a sudden you find out that it's probably not the best way to do it, how should people react?
Mm-hmm.
Yeah.
If you're a true scientist... which I think we all are, to a certain fashion. Well, I'd like to think we all are. If you're a true clinician, it should make a difference.
Yeah.
You should go, okay,
Yep.
let's do it this way now.
Yeah.
Right?
Yeah.
Like, you should be so invested in one thing that you get really butthurt when people tell you it's actually not right.
Yeah.
And that doesn't mean that everything you've done for the last 20 years is useless.
Right.
I feel like people have a hard time
Yes.
separating those two things.
100%. You got it.
Yeah, just because we're not putting a bone in a different place and now it's going to be there for now because we did the thing.
Yeah.
It doesn't mean that what you did is useless.
Yes.
Like because there are all these other contextual impacts or, the neurological, etc. Just putting healing hands on a person, those kinds of things, just looking
Our
at
words, what we say.
Yeah.
Yep.
Yeah, so there's a lot more to that. In general, though, so I guess it's unfortunate that we see all this stuff in our schools still. I don't know if I'm reassured or disappointed that some of these myths, I thought that maybe they were exclusive to chiropractic, but I was surprised to at least read on the internet, if you can believe what you find there. But from what I understand, and somebody correct me if I'm wrong about your osteopathy or PT school, but I think they're learning similar ideas of like right rotation, those, the joint is like this, let's push on it in the way that we, you know what I mean? So it seems like it's unfortunate that there's still a lack of evidence out there, but I guess in general to students who are learning this stuff and still trying to wrestle or like trying to digest the information, first of all, and they don't have any room to second guess it at the same time.
Yep.
What do you wish that, flash back to when you were a T5 and you were having an existential crisis?
Seriously.
What do you wish you had known in chiropractic school that you know now that might be helpful for students?
That's a really good question. What would I have wanted to know? I don't know. I think that some of this higher level conversations that we have, I think I would have been terrified because I would have been confused. And I would have been, well, it doesn't work, so why are we doing it?
Yeah.
And, because when you're when you're learning all this stuff, it has to be black and white because you can't comprehend the gray yet.
Yeah.
But, like I said, a clinician has to be in the gray. It can't be living in black and white. Mm-hmm. So I think as a student, I would have been very discouraged. I would have been like, well, why am I spending all this money to do this stuff that we know doesn't really make a difference? And I think it comes down to actually is that what we were talking about off camera is that you have to know the reason why things are told to you the way they are to understand why maybe that's not the right way, right? Sure. If you would never learn about palpation skills and biomechanical, maybe dysfunctions or whatever you want to call them, if we were never taught that, we also wouldn't know what it to look like if it was that. Do you know what I mean? And like we just talked about, there's no black and white, so it's never always 100% this, it's never always 100% that. And if you had no context of it, then you don't know anything, right? I mean, that's as simple as it is. So we were talking about ultrasound.
Yeah.
Okay. We used to think ultrasound was great. We do it to everyone, whatever, right? And we look at the literature and we know most things are better than that in regards to the treatment options. But if you don't know how it works, you don't know anything about it, you just know it doesn't work.
Yeah.
Well, it's not really enough. You need to know why. You need to know what the mechanism is, what we thought it used to do, why we know it doesn't do that anymore. That's the part that I wish you'd get taught more of. Yeah. You get taught the first part. You don't get taught the third part.
No.
And, maybe even though we know it doesn't work for certain things, there might be a time for it to be used. Right?
Yeah.
That's how we should be taught. That's how you all should be taught. It shouldn't be, this is what this is, and this is what that does. Next. When do I use it? Well, it does this.
Yeah. Okay.
But we have literature to show it doesn't do that.
Yeah.
Well, does that make it wrong? It just means that that's not the time to use it.
Yeah.
That's where I want to get to. That's the next level in your education is you've learned this wealth of knowledge, and now you need to find out, well, what does any of that mean? And is that accurate? And is that going to give me the best outcomes for my patients?
Even the craziest ideas that people have seem to, if you're willing to invest yourself in it a little bit, then you might, glean some fertilizer for better ideas in the future, So it's like that maybe not know thy enemy, but kind of. I mean, if you just close yourself off to ideas that are counter to the way you think, that oppose your beliefs, and I'm not willing to discuss it. You said what I do is bullshit, and screw you because I know it's not.
You got it.
Then you just die stuck in the mud.
Yeah.
But if you allow those ideas to seep into your brain and you actually spend time, if you're an atheist, read the Bible. I'm not Christian, so I'm not trying to make some plug for the.
But I get what you're saying.
Whatever it is that I just had a number of discussions with somebody on our campus who thinks totally opposite to me, and he shared a bunch of research with me. Some of it I have read, and I didn't think much of it, but that's okay. I'm gonna read all of it, and I want to see what's in there, because even if the idea isn't working in its current form, in that version, well, if we give it an updated version, then or we give it a reboot, there might be something valuable. Like the ideas, people don't come up with ideas for no reason whatsoever.
Right.
Like chiropractic, there was some voodoo involved, but it turns out that for whatever reason, it does seem like 100 and whatever 25 years later, we're still helping people. Still not sure why. But it seems to be helpful.
Well, and literature would show that we do help people, right? I mean, you look at the best guidelines, they show that manipulation for neck pain, for back pain is in there. As a first or second course of treatment. Movement, positive affirmation to continue to live a healthy lifestyle, and manipulation. Those are the things we know work. So, I don't know. That's it's simple, and you're 100% right. It really is just, again, just what we were talking about, stop living 10 feet looking down in front of you and look 30 feet up from the sky, right? And you see more. You understand maybe how things that you thought were maybe aren't exactly that way. Not that they're wrong. They're just maybe not the way that you thought they were. And that's how we need to look at everything. Man, that's musculoskeletal. Cool.
I think that's probably a good note to end on. So I know you gotta get to clinic, and we got some midterms that we gotta go kick some ass on. So
yes, sir.
We appreciate you joining us.
Yeah, boys.
Thank you.
Yeah, man.
Look to our
good stuff.
Yep.
Boom.
Thanks.
Boom. Cool.
Easy. Be sure to like and subscribe and all that stuff, because all the stuff. So.
All the stuff. Love it.
They know what to do. They see videos. You see videos all the time. Press the buttons.
If you haven't YouTube before, go home.
Yeah, figure it out. All right. Thanks.